Right, good afternoon. Welcome to the Basic Life Support Session and Advanced Life Support Session for technicians at King Edward Hospital. This is expressly for the purpose of keeping you updated with your basic life support algorithm and accreditation purposes at King Edward. Okay, so the Australian Resuscitation Council in 2010 talked about the chain of survival. This is where we know that if there is early recognition of the unwell patient with early chest compressions, CPR, of the patient who is arrested, followed by early defibrillation in a shockable rhythm and good post-resuscitation care in someone who's had return of spontaneous circulation, all of these in a chain leads to better outcomes of the patient. So in terms of code blue medicals on the ward here at King Edward, or in attending an unwell patient, we know that the AORC chart, or the adult observations, not sure what the R stands for, chart, otherwise known as the rainbow chart, is all about trying to pick up the deteriorating patient prior to the patient arresting. So if you look at the different boxes, if someone's in the orange or the pink area, or even the purple area, hopefully these are clues to the primary caregiver or the nurse looking after the patient that this is a patient who is seriously unwell and therefore needs help. So when we see an unwell patient, an easy framework to keep in mind would be to use the A, B, C, D, E approach. I don't necessarily expect you as technicians to have to do this, but it's good to know what we as medical practitioners might be using as a framework to try and assess the unwell patient and manage them. But also sometimes you might be the first person to arrive at the bedside of the patient who's unwell, and you may need to try and institute early measures to prevent the patient getting worse if possible. So this is a very simplistic or simple way of working through the different systems and to try and prevent a cardiac arrest. So A is for airway. So if you see the patient who's unwell and they're moaning or groaning or talking to you, you know at least that they have a patent airway because they're moving air, and two, they're breathing because you need to be breathing in order to move air. So you can say, okay, airway is patent and they're breathing. Along with airway, you should always chuck on oxygen on the patient, and then move on to breathing. Moving back to airway, obviously make sure there's nothing obstructing the airway. Foreign bodies, you can use your Yanker sucker to suck out any sort of blood or muck in the mouth if they've vomited, etc. Or give them some jaw thrust or chin lift to open up an airway that might be partially or fully obstructed. Moving on to breathing, obviously look for respiratory rate, chest rise and fall. They might be using accessory muscles for breathing. Put on a pulse oximeter to check their saturations, and along with breathing you can feel for the trachea to make sure it's midline, and have a listen to the chest if you've got a stethoscope, or provide a stethoscope for someone to listen to the chest. Moving on to C, circulation. Things that you can do: put on a blood pressure cuff, put on ECG monitoring, looking for heart rate and ECG rhythm, capillary refill, and also looking at perfusion of different organs, so such as a urine output to see how the kidneys have been perfusing, and looking at drain outputs, make sure that they're not getting hypovolemic from bleeding out, for example. And anytime you find something that's wrong or abnormal, you need to treat that. So, okay, so saturations are 92%, put on the oxygen mask. Their airways partially obstructed, give them a jaw thrust. Circulation, blood pressure 70 on 40, they don't have a cannula, put in a cannula, put up some fluids. They're bleeding, order some bloods straight away. Okay, once all those things are done, and if you've got enough people you can do all those things simultaneously, you need to move on to D for disability. There are different ways of measuring disability. What we mean by disability is obviously mentation of the patient, okay? Looking at the GCS score, the Glasgow Coma Scale, which is out of 15, can be quite difficult to calculate. The easier way of looking at their mentation is using the AVPU score. Okay, this is A for alert. If the patient is talking to you and answering your questions appropriately, they are alert. V for responding only to voice. If they're not responding appropriately, but they will open their eyes when you yell their name, that's V. P for pain. So if they are responding only to pain, like a sternal rub, they're obviously heading towards being unconscious, and U is unconscious or unresponsive. In terms of the GCS score versus AVPU, if the patient is around a P for responding only to pain, that equates to about a GCS score of 8, which from our point of view means that we need to look at securing the airway. And if we've done A, B, C, D, we need to move on to E, and exposing the patient for the purpose of looking for a cause of them being unwell. So what has caused this peri-arrest or deteriorating patient? Do they have bleeding? Is there PV bleeding? You won't find that unless you expose them and have a look. Do they have a swollen calf? It could be a DVT. Do they have a rash, which could be anaphylaxis or allergy or something? So E for exposure. So that's the unwell patient, the peri-arrest patient. Always start with A, B, C, D, E. Now moving on to the basic life support algorithm. It hasn't really changed much in the last sort of 10 years. The key difference is this S that they've stuck in here. It used to be Dr. A, B, C, D. They've stuck in the S because people were starting to do chest compressions, and meanwhile they haven't called for help. So they're stuck there doing chest compressions and no one is coming. So in the hospital setting, we send for help by pressing an alarm bell if it's in a theatre, or if we're anywhere else without an alarm bell, to pick up the phone and dial 55. Once we've done DRS, we go through our A, B, C, D. So open the airway, check to make sure there's no obstruction. B, is there any breathing? If there is no breathing, and most people say you don't have to feel for a pulse. It's up to you. If you want to feel for a pulse, we say don't feel for more than 10 seconds. You can't feel anything in 10 seconds and they're not breathing, they're unlikely to have a pulse. So what we teach in the ALS course is basically confirm arrest by looking for signs of life and breathing. If there's no breathing, then start chest compressions. And in terms of chest compressions, we're talking about 100 beats per minute. Easiest way of remembering that is 2 per second. and after every 30 compressions, give 2 breaths. If it's one person CPR, it's still 30 to 2. If it's 2-person CPR, you are still doing 30 to 2. Okay, so that's basic life support. Once the defibrillator arrives, then you can move on to your advanced life support algorithm. So just to recap, confirm cardiac arrest, look at patient response, open the airway. Patient is arrested, you call the resus team by calling 55 and start your CPR. Compressions should be in the centre of the chest at a rate of 100 per minute. If it is a gravid patient who has a large uterus, the chest might be shortened. You are still compressing in the centre of the chest, but it may just be slightly higher than you would expect. The aim is minimal interruptions, and if an airway is put in, either an endotracheal tube or an LMA, if it is sitting well and it doesn't have much of a leak, then you can do asynchronous compressions. Just continue at 100 a minute, followed by 8 to 10 breaths per minute. Pregnant patient, given that we're at King Edward, BLS and ALS is pretty much the same as an adult, following the adult algorithm. The 3 key differences would be left lateral tilt in the pregnant patient who's more than 20 weeks, early perimortem caesarean section. So if someone's arrested and you're doing CPR, then you should be thinking about doing a perimortem caesarean section from the start of the arrest, and start cutting at 4 minutes and get the baby out by 5 minutes from the onset of the arrest. Okay, moving on to the advanced life support algorithm. Okay, so we move on to this algorithm once we have a defibrillator attached and drugs available. So once we have the defibrillator attached, we should be attempting to assess the rhythm as soon as possible. If we have already started chest compressions, then we have to do what we call the defib dance. I'll touch on that a little bit more in a second. But then when we come to looking at the rhythm, if it is a shockable rhythm, we would immediately provide a shock and then go back to CPR for another 2 minutes. This is called a loop. So at the end of 2 minutes, we would assess the rhythm again, and if it's shockable, deliver another shock, and this time we would be giving adrenaline 1 milligram after the second shock. Okay, once we've started giving adrenaline should be given after every second loop. Whether or not we go from a shockable to a non-shockable rhythm, or whatever the rhythm might be, if they're arrested, adrenaline is given after every second loop. If you come to the third loop and they are still in a shockable rhythm, then amiodarone 300 milligrams is given after the third shock. So looking at defibrillation, there are different types of defibrillators out there. The ones that we have on the ward are the automated ones with a shock advisory mode. You will hear a voice that says, please connect the electrodes and attach the pads. And basically it's a 1, 2, 3 numbered buttons that you basically just follow and listen to the voice. In the shock advisory mode, you cannot continue compressions while the machine is trying to analyse. But in a manual defibrillation mode, this is what is current recommendations, and I will go through that, what we call the defib dance, in a second. Looking at safety, pad placement is important. Obviously there are pictures on the pads that tell you where to put the pads. It doesn't matter if you've got them back to front. The idea would be to make sure the heart is in the middle of the two pads. So whether that is right subclavian area followed by left axilla, or biaxilla, or anterior posterior placement, all of those are appropriate. The main thing to look out for would be big breasts. You want to avoid tissue that is going to prevent you from getting the shock through to the heart. Nipple rings, GTN patch, pacemakers, you want to be more than 10 centimetres away from the pacemaker. Other things of safety in the obstetric setting would be CTG belts and the fetal scalp electrodes, things you might want to remove if you get a chance before you actually shock a patient, if possible. In terms of energy levels, the default is 200 joules. All defibrillators now in use are pretty much biphasic. I haven't seen a monophasic one in years. And some manufacturers recommend a slightly different energy level. For example, the Philips, I think, recommend 150 joules. But from our point of view, all the defibrillators in King Edward, default is 200 joules. And even in the Philips where they recommend 150, it can go up to 200. So if you come across a defibrillator that you're unfamiliar with, use 200 joules as the default setting. That is what we teach. All right, the defib dance. Okay, so in recent years they've noticed that whenever we come to check for the rhythm on the defibrillator, there's been this big lag in time where no one is providing chest compressions, and therefore there's no cardiac output. So in the most, or maybe 2010 it was, we changed the order of things as we come to assess for the rhythm in order to decrease the amount of time off the chest, otherwise known as the defib dance. So a good acronym to use is COACH, C-O-A-C-H, where the person manning the defibrillator, once we've come to the end of the loop, the end of 2 minutes, and it's time to assess the rhythm, person manning the defibrillator would say, continue compressions, oxygen away, all clear, I'm charging. Press the charging button on the defibrillator. Once it's charged, and you'll hear a high-pitched sound followed by doo, followed by doo 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 doo. That means it's charged. Then you yell hands off, and the person who's doing chest compressions would say I'm safe, and you would assess the rhythm. And if it's a shockable rhythm, you would shock while looking at the patient to make sure that no one else is touching the patient. Or if it's a non-shockable rhythm, you would dump. And you would dump by pressing the black wheel button on the defibrillators that we have here. So we will go through that again in our hands-on scenarios after this talk. So that's the shockable side of the algorithm. If we were faced with a non-shockable rhythm, the first thing we should do is give adrenaline. So there's always something to do when you come to assess the rhythm. If it's shockable, you have to shock. If it's non-shockable, you should be giving adrenaline 1 milligram IV immediately. Okay, and then once adrenaline has been given, it's then given after every second loop, regardless of whether it's shockable or non-shockable. Sometimes patients flip in and out of a shockable rhythm, depending on what's going on, which can make it confusing whether we're giving adrenaline or shocking, but once adrenaline's been started, it's after every second loop. Okay. When we are doing our 2 minutes of CPR, we should always be thinking of other things we need to be doing. So things like airway adjuncts, putting in an intertracheal tube to secure the airway, giving oxygen, attaching waveform capnography. This is now the standard of care in arrested situations. They have looked at capnography as a marker of successful chest compressions, I guess. If you've got end-tidal CO2 over 10, that means chest compressions are effective and providing a good cardiac output, so to speak. Thing to remember is obviously if the endotracheal tube is in the trachea but there is no cardiac output or not good enough chest compressions, you're not going to get CO2. Other things to do during CPR, obviously put in an IV drip if the patient doesn't have one, or if you can't get intravenous, then intraosseous access is the next port of call. If you can't get either of those, you can give adrenaline down the endotracheal tube as well, 3 times the usual dose, but the preferred method is IV or intraosseous. And obviously plan your action before interrupting compressions, which is your defib dance. All right. So we've already mentioned this. If you have a secure airway, you can do continuous chest compressions and asynchronous bagging of the patient at 8 to 10 per minute. Things to remember: avoid hyperventilation, that has been shown to be bad for outcomes, and attach waveform capnography. Okay, we've already talked about this. Okay, if you are in the shockable side of the algorithm and you are coming up to your 3rd shock, you need to prepare your amiodarone, which is 300 milligrams in 20 mils of 5% dextrose, and after the 3rd shock, give it as a big push followed by a flush. Okay, in an arrested patient, this is not going to cause more harm. In someone who may be peri-arrest or just hypotensive and in VT, you would choose to give amiodarone a lot slower, say over 20 minutes. And atropine is no longer in the algorithm. A specialist anaesthetist or cardiologist or a specialist might choose to give atropine in a peri-arrest situation if someone's bradycardic, but we are not teaching that on the ALS course to the masses. All right, so what to do? So someone's arrested, you are doing your chest compressions and your assessing the rhythm and shocking or not shocking and giving adrenaline. Meanwhile, you have to try and consider correctable or reversible causes as to cause of the arrest. The easiest way of remembering those are the 4 H's and 4 T's. And here's a nice little diagram to help you remember what they might be. Hypoxia, hopefully you're treating that with giving them oxygen. Hypothermia, if a patient is an inpatient and they are arrested and they are found to be cold, hypothermia is unlikely to be the cause of the arrest. They are more likely to have arrested a while ago and have become cold since the arrest. If it's a patient who's an outpatient and it's winter and they have come into ED cold and arrested, hypothermia per se could be the cause of the arrest. And there's a saying that you can't be declared dead until you're warm and dead. something to think about. Other H's, hyperkalemia or hypokalemia, and hypovolemia. You would have put in a cannula and putting up fluids or blood as needed. In terms of the hypokalemia, you would be taking blood off when you're putting the cannula, sending that off for a VBG or UNEs, FBE, CK troponins, coags, etc. The 4 T's, toxins. So with that, you'd be looking through the drug chart, looking for injection marks, trying to work out what drugs are going into the patient, whether there's been a drug error or something hasn't been reversed as it should be post anesthetics. Yeah, all those other drugs you have to think about. Tension pneumothorax, you'll be feeling for your trachea to make sure that it is not displaced off to the side. You'll be listening for your absent chest sounds and hyperresonance to tell you where the tension is, which side the tension is. And if you think it is a tension pneumothorax, you would treat that with putting in a 14 gauge cannula into the second intercostal space in the mid-clavicular line, followed by putting in an intercostal catheter. T for tamponade, very difficult to diagnose, cardiac tamponade. It would be on an index of suspicion, so in a patient who might have had a central line inserted recently, they might have perforated that and caused a cardiac tamponade, or in a chest trauma patient. For example, those are sort of key signs that it might be a tamponade, but very hard to diagnose unless you've got an ultrasound or echo. And final T, thrombosis, which could be a DVT or a pulmonary embolus causing the arrest, which is not that uncommon in our setting. And obviously that also includes myocardial infarction, thrombosis in the myocardium. So those are the 4 H's and 4 T's that we need to be thinking about as we're doing our CPR and trying to manage this arrested patient. So just briefly, we're going to go through the rhythms that you might see on the defibrillator, and I don't expect you to know what all these rhythms are, but I just want to expose you to some of the common rhythms that might come up. And in the arrested situation, all I want to know is this a shockable rhythm or a non-shockable rhythm? Okay. So this one here, okay, is obviously shockable. Okay. And this one here, regular, wide, broad, complex, in a pulseless patient, it's VT, pulseless patient, shock. This one here, doesn't matter what the actual rhythm might be. Someone might be standing there trying to calculate whether this is a 2-to-1 block or whether this is a wanky back or a second-degree heart block, etc. It doesn't matter. If the patient is pulseless, it is a non-shockable pulseless electrical activity. In the olden days, we used to call this EMD, which is electrical mechanico dissociation. In either case, they don't have any cardiac output, whatever the electrical rhythm might be, so it's non-shockable. You continue CPR and give adrenaline. Same with this, if the patient is pulseless, it's non-shockable, you continue your CPR. This is probably the most common rhythm you're going to see, which is a sinus tachycardia in someone who's got a pulmonary embolus or hemorrhage. This one, non-shockable, obviously. Asystole, it's always a bad sign. Make sure that it's not the electrodes that have fallen off the patient or the paddles have fallen off. But usually in our defibrillators, if the pads have fallen off, then you just get a dotted line. So that's your advanced life support algorithm. And if you do get return of spontaneous circulation, then we move into this post-resuscitation care phase. And the goal here is to restore normal cerebral function, try and stabilize the cardiac rhythm. That might be with some inotropes if needed, so a bit of phenylephrine or metaraminol or adrenaline infusion if needs be. Try and maintain adequate organ perfusion, so in the hours post-resus we're putting in urine catheter and making sure that the kidneys are perfused and they're getting urine output. And if someone has had a primary VF arrest, then we are looking at mild cooling of the patient to decrease cerebral metabolic rate to try and protect their brain. And as always, if you get a peri-arrest patient, so once they've arrested and you've got them back, then you go back to your A, B, C, D, E approach to stabilize everything, okay? Make sure that all their systems are being looked after. Okay. Are there any questions? So in summary, maintaining high quality chest compressions is important in the arrested patient. Early defibrillation in the shockable rhythm is important, and remembering your 4 H's and T's for potentially reversible causes. And this is followed by good post-resuscitation care. And in King Edward, obviously we would be thinking about disposition of the patient, where we're going to send them after they have had an arrest and we've managed to resuscitate them. They need to be transferred somewhere else to intensive care, for example, depending on the cause and duration of the arrest. Okay. All right. Thank you very much for listening. The only thing I wanted to mention, which I forgot to mention earlier, is that once you've shocked the patient at the end of your 2 minutes of CPR, once you've shocked the patient, even if you see a potentially perfusing rhythm on the screen, you need to do your 2 minutes of chest compressions if they are tolerating it. This is to provide the myocardium with enough blood, oxygenated blood hopefully, for it to maintain and stay in this potentially perfusing rhythm. So there's no point feeling for a pulse immediately after shocking, even if you see for example, a sinus rhythm. This is, if the patient will let you, you need to continue your chest compressions for another 2 minutes to stabilize the myocardium before checking the rhythm again. And if the rhythm at that point is a potentially perfusing rhythm, such as a sinus rhythm or sinus tachycardia or PEA type rhythm, then you can feel for a pulse or look for signs of life like breathing or movement. The only time you do interrupt your chest compressions is if the patient pushes you off the chest or starts groaning or moaning or moving, in which case you can stop your chest compressions and assess the rhythm and provide support with other measures such as inotropes, etc. Okay. Thank you again.